So some of the things we have been doing in the last couple of days. Might now start becoming a little bit more familiar. Things like the data processing, things like the visualization, which are just aspects of some of the things that health data scientists are doing. And a large part of this work took place about 3 years ago when we were putting together this program. There was a large grant that was awarded to the group with the FAR Institute, and this is how this MSc came about. So a lot of the things about, okay, so you walk through the door, they tell you, we've got a need for an MSc in health data science. Okay, where do you start? How do you put together the curriculum? What are you gonna say to these people? Well, you look at what the health data scientists are doing. So we looked at the work that was going on in the department with the same data bank and everything. We looked at the work that individuals were doing, researchers were doing. We looked at the work that we were doing, a sample of which you saw, and we put together this thing. So this presentation here is the things I'm going to say is a little bit about what is it that they do? What is this animal we are preparing? What does this person do? And to describe this, we're going to start from the healthcare environment, then look at the work of those, and then a little bit about the skill set. So a little bit about the bigger picture. This is a very abstract model of the healthcare environment. This thing is going on day in, day out. One of the things I like to stress here when I'm giving this talk, even to students, because this is part of our data modeling module, is that our the basic relationship is between this actor and that actor. This relationship has been going on for ages, ever since someone said, "Doctor, I'm in pain," and doctor said, I'll see what I can do about it. So this thing has been going on for ages. The whole thing around it, whether you're going to do it by observation, by touching someone, by getting their blood pressure, feeling their temperature, or if you have a laser non-contact thermometer or whatever, it's immaterial. This thing is going to go on, whether you have technology or not. So patients present themselves to investigators. Investigators are making observations. Sometimes these observations or these actions they want to take, they cannot do them on their own, so they will instruct investigators to take actions on patients and go through this cycle. The investigator has in their mind published evidence-based, things that have happened out there anyway, and also opinions, assessments, goals, plans. A patient presents themselves to the doctor, and the doctor thinks, I've got to get them to that state. Not necessarily complete cure, but in improvement. Not in large steps, maybe in smaller steps, and so on. And from all this interaction, what you get, and what is our incredible main interest, is data. So out of all of this interaction, what you get is data. We call them routinely collected data because these are the data that the doctors need to do their work. The medical doctor's job, their main mission is to care for the patients. Whether these things are accumulated, and if you start looking at them, you start seeing patterns and things like this, is secondary importance. So these are the routinely collected data. And just as we went through this model briefly before, we've got observations, we've got instructions, we've got actions, but at the same time, we also have the demographic data. Where do these people come from? What is their handedness? What is their primary language? And so on, and so on. We also have things like the plan, everything recorded so that you know that the medical doctor was trying to get the patient to that state, and so on. And also audit information in case things are not going very well. And this is, again, very nice straight lines, you know, and boxes and models, and everything is in order. But in reality, that thing is not exactly straightforward. Because all of this data, at the best case, they're going to be directly captured. Some of them are going to be transcribed. Some of them will conform to some standard templates. Others will not conform to a standard template. It's just that someone is capturing the data to do their job, and they happen to be available in some spreadsheet, in some Word document. Some of them are in standard databases. Some of these data are coming from clinical and administrative systems. Some of them might be disease-specific, like cancer registries, like multiple sclerosis, and so on. But the point is that this very neat picture is a bit messy in reality. And so we capture this data, all right? All of these data, they go into large containers like this. How do these data look like, right? So this is a snapshot of a real data set. And you can see that it is just reams and reams and reams of numbers. These are identifications, dates of events, what happened. Basically, what this is a little bit like an aircraft log. At time X, this happened. At a later time, that happened. And first we lost the electrical system, then we lost the fuel system, then the rudder jammed, then I don't know how many of you are going to travel by airplane. Maybe I should. Anyway, then we had a problem, all right? So this is a little bit like a book of life. This is what is happening to every person. This is who it happened to, this is when it happened, this is what happened, and this is a little bit of information associated with what actually happened. And these two things, which I'm not going to go into great detail now, but this is where it happened, and this is when the bit of data was going into the database. Right, so this is it. That's what you see. You don't see XYZ got flu. You don't see XYZ got stroke. You see XYZ got ABC3 dot something. And we've got to make sense of it. So, right, we collected all of this data. These things are going on as a result of this process, as a result of that process. It goes on every day, every day, every day. You generate all of this data, and you accumulate on this table, let's say, more and more and more and more and more. And then what? Well, basically two things. You either do business analytics or clinical research on the back of accumulating all of this data. So we've got things like, how much do we spend? What do we spend it on? How long does it take for that process to happen? How long does it, how can we improve? How can we make the same thing cheaper, but with the same quality, and so on? And on the other side here, we've got the clinical research kind of thing. So and once you have this presentation, all of these things are links, and you can see examples of. They are from the UK, so business analytics, I've got here the quality outcomes framework and commissioning services. Quality outcomes framework is something that is going on in the NHS in the UK. The organization is caring for people, and you've got metrics by which you sense how well do they do. So you've got, for example, the list size, the registry size, how many people are there registered for every GP surgery. And then you've got performance indicators, which are updated yearly. And once you click there, it will take you to the website where you can actually get data down to the surgery level. Of course, it's aggregated data. You're not going to get access to the individual data, but you will find out that a surgery in Cornwall has that many people with obesity, dementia, neurological disorders, musculoskeletal disorders, respiratory problems, and things like this. And on the other side of this, we've got clinical research. And I've got a few things there, including the Secure Anonymized Information Linkage Project, which is going on at Swansea University for more than 10 years now. And clinical research is all about trying to make sense of things that were not, so as we said before, these data are captured for the primary care. But then what we are looking for now is things like, why do people get sick? Why did this person have to go to the surgery and report that they have a problem, whatever? How do they get sick? And things like this. So here is a little bit of an example for the Secure Anonymized Information Linkage project. And each one of these words is a lot of work. You know, secure is a lot of work, a lot of effort. Anonymized is a lot of effort and a lot of value behind it. Information linkage, immense work. But this is still going on. So this is what SAIL does in a way. So you have all of these little bits and pieces created within the NHS as a result of the interaction between patients and medical doctors. We cannot really access this data directly in a way that, you know, Athanasios Anastasiou has this medical problem. And like this is known to everybody. I wouldn't mind, but you know, that's personal information. You have to give them the opportunity to decide if they are going to share it. Another reason why I'm staying here in this security aspect is because this relationship is sacred. The relationship between a patient and a doctor is sacred. If the patient has any reservations that the doctor is going to go out there and sort of broadcast all this information or use it against their best interests, then they're not sharing everything with the doctor. Then the doctor cannot do their work. So this relationship is sacred. And all of this work that is done to secure the identity of people when you still are going to mine their data is adding a lot of value to this operation. So the way this is handled is by delegating the anonymization to the NHS Wales Information Service. I have to say, for those of you that are not aware of the details of the country, we say United Kingdom, and it's 4 kind of individual regions. So Wales is one of them, England is another one, Northern Ireland is another one, and Scotland is another one. So in Wales, we've got the NHS Wales Information Service, NWIS, which is handling the anonymization. What does that mean? It means that Athanasios Anastasiou becomes number 23562, something like that. And then what we get, or what SAIL gets, is reams and reams and reams and reams of this type of information that we saw before. It's impossible to tell who this person is. This works only one way, not the other way around. So if you have this, you can't work back on who produced the data. And what happens next is that the other thing that SAIL does very well is that it picks up all of these little bits and pieces of information that are created as a result of the interaction between patients and doctors and brings it together in what is known as information linkage, which is a very difficult problem. To give you a very quick example, if you had primary care data, GP surgeries, you just go to the doctor and you're saying, I've got a fever, they give you a pill, boom, it's gone. Secondary data is when you have to be admitted to the hospital. These two data sources are not necessarily talking to each other. So the fact that I was hospitalized, you know, I went somewhere in the UK, I was hospitalized, and then I returned back to my home and I go to the GP, it's not necessary that these two are talking to each other. If I say to the GP, I went to the hospital, that's all right, but the GP is not necessarily going to know that I was hospitalized or whatever. So here is the added value. All of these bits and pieces of information are coming together. Now you might say, so what is so difficult? We just join the information on your unique number. I just say, give me everything that you have for number 1, 2, 3, 4, 5, 6, 7, 8. And that's fine. You know, if you have a social security number, if you have any sort of unique identification, you can link the data in this way. But there are cases where you have data sets that you know that you have data for a specific patient, but you don't have their identifier. And that's where information linkage comes in. There have been books written on doing this thing. And so you start creating hard or soft metrics, and you're starting to assign probabilities and say, well, these two records, 80% that they belong to the same person, but these two records, really 0%. It's impossible that they are. So you match the name, surname, address, date of birth, the father's name. It's a huge operation. So we covered secure, we covered information linkage, we covered anonymized. Again, and then what? Well, then when you have all of these things brought together in one unified data source, you make them available to researchers as one unified source. Researchers don't have to go around and say, okay, what do I want to do? I want to examine if kids that are coming from families that had to travel around more frequently, if their educational attainment is lower, for example. So I want to study how does this how do these troubled times maybe in the family that translate to they had to move around a lot, how does this impact their education attainment, right? I don't have to go around and picking up all these little data sets and, you know, who do I have to ask? I have to go to the school, and then they moved, they went to another school, so I have to go to that school, and then I have to... You come to SAIL, and of course, because this operation has a huge amount of a huge potential for doing both good and bad to an extent. So, you know, data analysis and mining information and all of these things is a double-edged sword. All of these things is becoming available to researchers as a unified data source via the SAIL gateway, but more importantly, via an information governance procedure. Which means that if you are a researcher, you don't just log in to some machine and access all of this wealth of information. You have to report to SAIL, why do you want to do this? How are you going to do this? Where are the data going to go? How are you going to ensure that you still protect this basic privacy of those people, which again traces back to protecting that relationship. So great operation. All of this mining, and you know, we'll find this and we'll find that and we'll find this pattern and we will cure everybody, but still protecting the person who you're doing the research for. And again, as before, if you click on this link when you have the presentation, then you're going to get a link to the research projects. There are, the last time I counted, which is not yesterday, the last time I counted anyway, there were maybe more than 100 papers, more than 100 projects that have come out of this operation. And this is a quick overview of the kinds of data sets that you can find in SAIL. Some of the names might be cryptic, but we can see things like National Community Child Health Database, NHS Direct Wales, Cancer Incidence Registry for Wales, national screening programs, congenital abnormalities, ambulance service data, national pupil database. So you've got, it's an incredible wealth of information available for research projects, available for people to probe research questions. And with this background, which as I said, recently there was the celebration of 10 years of SAIL. Of course, SAIL had been going on. I mean, if you see some of the papers, some of the early papers, they definitely are more than 10 years ago. But this is the backdrop where the MSc in Health Data Science was created. The reason I'm mentioning this is because, as I said before, we had to look at what do these people do? How are they different? Why don't you just get a researcher and call them the data scientist or health data scientist? I like models very much. So again, we have here a model. Oops, sorry. We have here a model. And I'm not going to talk about the NHS. I'm just calling it a healthcare entity, because these data scientists might work in an insurance company, or they might work in a setting where you don't think that they are doing health, but they are handling health data. This healthcare entity has a business process which generates the data, as we said before. And you will most definitely have a domain specialist. That's your medical doctor. That's the person that knows everything about the disease. Well, almost everything about the disease you are interested in. So we're talking about things like they know everything about depression, or they have the questions about depression. They are at the forefront. And you've got people like director of operations. They probably respond to some funding body. But both of them, they share a similarity. They are not technical people. They have questions. This person has questions. How do people get sick? Why do people get sick? They have research questions. That person, that role, has other questions like, what do we spend? How do we spend? Where do we spend it on? And so on. But all of the information, all of the data that will answer these questions is behind all this brilliant technology and all these methods and algorithms we have seen in the last few days. So this is what this person does. They sit in the middle. On one, like some sort of adapter. On one side, they listen to research questions. On the other side, they translate to queries. They translate to algorithms. They translate to models. They translate to numerical methods. They translate to all these different things. They are bombarded with questions. And they have at their disposal tools to answer these questions. So obviously, you need methodology, all right? If tomorrow there is a nuclear disaster, all right, maybe I should revise my examples, airplanes falling, nuclear disaster, but there is a point behind this. Science and the way we think has nothing to do with this. It has nothing to do with computers, has nothing to do with pressing buttons. It's primarily a way of thinking. So that is what you need to answer these questions, first of all. And of course, as we said before, digital data resources, some of them might be outside of this perimeter. So you've got data inside the healthcare entity, but you combine it with data outside of your own little world. That's where you need the linking. You have, again, computing resources. Some of them might be inside your organization, but some of them might be outside of it, and we saw some really good work that is happening in Amazon and an offer that really, in an incredible way to people outside, where you can use the cloud computing, you can use farms and 30 computers connected already and set up for you easily to solve very difficult problems. And again, when you have pulled all this hard work and head scratching, there comes the time to present it. There comes the time to visualize it. And all of these are important, this one included, because these people remember what is happening at the interface. They have the research questions. They have some knowledge. But if you sit around and tell them, by the way, we did a MapReduce, and then we took the data from here, and then ran a t-test, and then this happened, and then that happened, and they're not going to see all of these things. So they want to know, so what? What are you telling me here? What is the answer to the question? So this is where the visualization bit becomes important, to really tell them the methods clearly. And so this is the outcome. This is what happened in the end. We put health data scientists up there, and that is the kinds of things that they do. These are the kinds of knowledge they need to have in the background. It seems a little bit of everything, but it is necessary, because that's how the environment works. It's not only about programming. It's not only about being good at Python. It's not only at solving equations. It's not only about doing integrals, differentiations, all of these things, understanding models. It's not only about that. It's not only about, oh, it's a CSV, it's fine. It's an XML. It's a, I don't know, a relational database. It's about bringing all these things together, along with things to do with, as we said before, privacy, clinical codings, ethics, things that are unique to the healthcare environment, and that you're not expected to get it in a general course, such as, things like, a lot of people who are working in these domains might be gravitating from other domains, but once you get into this, you will have to get to grips with the specialities of health, which you need to know, the little bits and pieces of healthcare that you need to know. And so, just to bring it together, that is how this, and this is just the last slide, I think, that is how we took the mapping of the skills and mapped it to the program. And basically, this is what the program of in particular, the MSc in Health Data Science is about. And that is it from me today. Healthcare is an incredible environment, very interesting, changing every day. That wouldn't be an exaggeration. With high risks. We're talking about the lives of people. This is incredible. Get something wrong, get a few numbers wrong, and someone's life might change for the, well, if I said get some numbers wrong, their life should change for the worse, isn't it? This is what health data scientists do. They translate research questions to scripts, to databases, to models, to some of the excellent things we've seen the last few days here. And they go into these huge databases and come back with the evidence. That's how we take decisions. The answers are in there, but there's a little bit of work to get into that data and bring back the answers. And that is it. I think that is it from me. As I said before, this presentation is littered with links, so you can click and find out more for some of the things that I have been standing here for the last 27 minutes. I'm almost overrunning, and I've been telling you about. So thank you very much for having me. That's it from me. Thank you. Do we have any questions? All right, yeah. Yeah, go on. I don't know if we're going to bring a microphone, but I think we can hear you. Go on. If sale is available to the public for free, the short answer is no. The reason for this is that all of this operation is costly. So there are people in the background that work with all these data sets that are coming from the NHS. They need to clean it up. They need to make sure that they are in the right format. They need to make sure that they blend with the already existing model, which is in the database. There's a lot of work done to make sure that the data that you have that your data are valid. Again, this is about adding value to sale. So, yeah. If you are interested in some data, I have to say, I know this is not very much of an answer, but it depends. It depends what you want to do. It depends how you want to do it. I suppose that if it is something which is very simple, it will have a different costing model than something which is very difficult. Yeah. Oh, that's where that was. Yeah. So I think it's fair to say that there is a cost associated with it. To answer your question, there is a cost associated with it, but there is also a process that goes with answering, with that cost, and with how are you going to access the data. It's a process that might also take a little bit of time, but all of these things are necessities. If you don't ensure, as we said before, it's all about protecting that relationship. And it's complex, but it's essential complexity. Yeah.
My question really is, in UK, I think this is why
yeah.
You have a very good, great NHS system.
Okay. Yeah. I have to say this is a little bit like echoing conversations we have had with different people the last few days. This thing didn't happen overnight. It seems to be working. It's a template. It's answering. It's like a solution to a problem, if you like. It's not necessary that if you replicated it here, it would work. There are a lot of things that are different, but it would give you a skeleton. A lot of the things that are happening in Sail are now, in a way, being made independent. So, for example, the technology that supports all of this linking and accessing and organizing the data and making them available, this is all packaged in its own right. You know, it doesn't have to be this data set or the other data set. It's just by abstraction, you can make it general. And you can have this template, this solution, and say, OK, now we're going to take it from Swansea, and we're going to apply it in that country or in a different setting. But so that is on the high level. In a way, you know, this is how this relates to this environment. But when it gets to actually implementing it, there are definitely going to be differences. There are definitely going to be things that are special to this environment. Someone here might be interested more in curing a disease rather than saying, oh, your name is in the data. I don't care if my name is in the data. We're dying here, you know, kind of thing. So these are definitely differences of this environment. And they are challenging, and they are, to an extent, they are up to the local researchers and the people who have the knowledge locally to start answering these questions. How can we do this? How can we make it reality? In an infrastructure that is dominated by mobile networks with their own differences in these social conditions, in these remote areas, where if you ask for something, it's not going to be there tomorrow. It's problems that you cannot solve 6,000 kilometers away. So to an extent, it is very much, you know, you can say this is a skeleton, we could adapt it. But what are these adaptations? It's up to the local researchers, to the people who are inside the environment. We can help, but I hope this answers the question.
Okay, this is one more time.
All right. This is it. Thank you.
If you've got any more questions, you're still here, right?
Oh, yeah, we're going to be here until tomorrow.
Exactly.
Yeah.
Okay.